Happy. It was good to have a chat, and I see there's still a significant number of people online. This is the final significant talk of the day. I had a great pleasure introducing Dr. Kevin Crofts, who's an ophthalmologist, works with me. He refers me patients for DCRs, which I still do occasionally do. But as part of our chat, I discovered that he's also one of the leads in the Glasgow Thyroid Eye Disease clinic, and he successfully manages patients there very effectively. He's currently involved in various research trials associated with that. And yeah, Kevin, thank you very much for speaking today.
Thanks very much, Owen. Thanks for the invite. Yeah, that's very kind. As Owen said, Kevin Crofts is my name. I'm one of the ophthalmologists in Glasgow. So thyroid eye disease. It's kind of a big topic. I've tried to rein myself in, not to talk about too much in one go. So we're going to talk a bit about the pathogenesis, a bit about assessing it, which is what we spend our time doing, and treating it. So it is an interesting disease. So thyroid eye disease, Graves' orbitopathy, same thing. So about 90% of thyroid eye disease is associated with Graves', but occasionally they're hypothyroid, like if they've had radioiodine, or they can be euthyroid. So it's depending on the study you read, it's found you get the eye disease between 20 to 50% of Graves' patients. So it's pretty common. Only about 5% develop moderate to severe, and because you could even miss mild ones, they might go past as a bit of photophobia, a bit of dry eye. But 5% develop moderate to severe eye disease, and 3% develop dysthyroid optic neuropathy. That's not an insignificant percentage. And so the risk factor as well, unstable thyroid function, so 90% of Graves'. Radioiodine can tip you over into thyroid eye disease. A high TSH receptor antibody, TRAB, that's what that abbreviation is. Smoking for, as you know, multiple reasons is a problem. But for thyroid, it's a real problem. Your odds ratio 2-to-1 of getting thyroid eye disease if you smoke, and you get it worse, and it drags on forever. And it's 5% more common in women. So the TSH receptors are present in greater numbers on the fibroblasts in your eye if you've got thyroid eye disease. The TSH receptor antibody found in Graves' can bind those receptors on the gland and in the orbit. And TSH receptor antibody is found in higher levels in those with thyroid eye disease. Insulin-like growth factor receptor is also now recognized as a component of this, and there's a good diagram of this in a while. So you can see there. So you've got your orbital fibroblast. So this is in the orbit. You got the TSH receptor there, but you've got the insulin-like growth factor receptor there, and the two seem to work together, and they're both needed for binding of the TSH receptor antibody there. So, and when the fibroblast is stimulated like this, then it causes all sorts of things. You get lots of hyaluronic acid produced, and that's hydrophilic, so absorbs water, so it swells. You get the stimulation of the adipocytes. They grow, they multiply, they swell, they get bigger. And you get differentiation of the fibroblasts into myofibroblasts, which have a kind of a smooth muscle component to them. And all of this, you go from an orbit with normal levels of fat, normal-looking muscles to fat swollen muscles, and an expansion of the fat. The same thing doesn't happen in everybody. Some people get soft tissue signs, some people get more muscle signs, some people get more muscle swelling, don't have the fat, some people the muscles aren't involved. So it's not the same for everybody. Anyway, the combination of all of this, that's just repeating the same thing there. The muscles swell up, the lids retract, your eye movements get impaired, and if the muscles are really swollen at the back of the orbit, you can crush your optic nerve. That's when you're in trouble. That's dysthyroid optic neuropathy. So the little mnemonic for get lid retraction in 90%, the little mnemonic for muscle swelling is I'm slow. So it's the inferior rectus is the most likely, then medial rectus, then the superior rectus and lateral rectus. It helps us differentiate from something like idiopathic orbital inflammation, where maybe it's the superior rectus is involved primarily. You go, maybe it's not thyroid. So the fat expands, and yeah. There appears to be a correlation between the CAS score, sorry, the clinical activity score. And there appears to be a correlation between the activity of the disease and how high your TSH receptor antibody is. TSH receptor antibody is slower to fall in smokers when you treat them, and it does go down when you treat with rituximab. So it does seem to be linked, but there's no perfect test either for thyroid eye disease. The natural history, probably Rundle's curve, has been around for decades now. So the disease, you go from having no disease, you're active, active. So the active phase here, and then it kind of burns itself, it plateaus, burns itself out, and then they're left with the disease. The active phase has burnt itself out. It's no longer, they're no longer inflamed, but they're left with lid retraction, proptosed eyes, that kind of thing. So generally, the time span varies from person to person. If you're young, fit, healthy, non-smoker, the disease might be gone in 3 months with steroids. And if you're a smoker, it might be still there 2 years later, grumbling on. So the fundamental questions we have to answer in the clinic is, well, is it thyroid eye disease? Is it active? Because no point in throwing steroids and rituximab at something if it's not active. How bad is it? How severe is it? Might be active, but it might be mild, so you don't really need to treat. And when did it start? If someone says, "Oh, people say they do say frog eyes," and so they say, "Oh, my eyes got like this, 4 years ago." Well, it's highly unlikely the disease is still active. They might have a bit of photophobia and a discomfort, but it's probably just because their surface of their eye is exposed. So when did it start is important. So is it thyroid eye disease? So thyroid eye disease is the commonest cause of proptosis. The terms proptosis and exophthalmos are used interchangeably. Proptosis kind of is all causes of a pushed out eye. Exophthalmos generally refers to it from being from thyroid eye disease. But we generally use the term proptosis. So, it's if there are hints such as they've had high TSH receptor antibody, they've just had radioiodine, they've known thyroid problems, they have lid retraction, especially with lateral flare. This is where the lid is wider at the side than it is medially. They're all good hints that it's thyroid eye disease, but you got to be a bit careful. If As a sort of a rule of thumb, if people are proptosed and retracted, it's thyroid eye disease. So if they've got a bulging eye and their lid is wide open, it's probably thyroid eye disease. If they're proptosed, if the eye is pushed forward, but the lid is low, the lid is ptotic, it's probably a tumor. As a rule of thumb. So this lady, you can see that right eye is displaced downwards. And she's got a bit of ptosis, actually. Her lid is low. So she had a solitary fibrous tumor, big lump here. So she's not thyroid. What about assessment? Most eye surgeons in the UK, we follow UGOGO, which is the European group on Graves' orbitopathy. So most units follow this. So that's what I'll go through today. There are other systems available, but we go by this. So one of the UGOGO recommendations is having a dedicated thyroid eye disease clinic. And for that, we have 2 ophthalmologists there, sometimes a trainee as well. We've got an orthoptist who are invaluable because they do the eye movements, they treat with prisms, fields, OCTs. Our nursing colleagues take bloods. They'll administer intravenous methylprednisolone, rituximab, and they're very much hands-on in educating and counseling people about the disease. And in an ideal world, we'd have an endocrinologist with us, but we don't. But we have got a lot of advice, same day by email, so that works. So in assessing thyroid eye disease, we use the clinical activity score. That's been around for a long time. And that forms part of the UGOGO assessment system. It's been modified to be a bit more user-friendly. So what are you looking for? Well, signs of inflammation, basically. If they're inflamed, they're active. You've got active disease. So pain. So they might have pain just in this normal position, primary position. Or they might have pain when they look around. That's a fairly good sign that the disease is active. The eyelids can be red and the eye itself can be red. The conjunctiva can be red. You might have swelling of your eyelids, swelling of your conjunctiva, which is called chemosis. The caruncle, which is in the corner, that can be swollen. You can have an increase in your proptosis, the exophthalmos, how much the eye is pushed out of your socket. And other things you need to look at is whether there's been a decrease in eye movement or a decrease in visual acuity. So this is the assessment form. Sorry, this didn't come out all that clearly, but you can probably see there the things you're assessing are their acuity. Have they got pain? Have they got pain when they move? Then have they got lid swelling? Have they got lid erythema? Have they got chemosis of the conjunctiva, conjunctival erythema, caruncle inflammation? You score all those and a maximum of 10, basically. So you end up, you score their inflammatory markers and you get a score out of 10. And it gives you a good indicator of how active they are. What it's also helpful for is you can see whether they're, the next time you see them, whether they're getting worse or whether they're getting better maybe on your treatment. The other very important thing that you have to figure out is, well, you're trying to figure out if they're active, first of all, with the clinical activity score. And then you figure out if they're mild, moderate, or severe. Basically, mild is they might have a little bit of dry eye, they might have a bit of photophobia, a bit uncomfortable. Moderate, so if they've got double vision, you're instantly into moderate. If they're quite retracted or got some corneal exposure, you're into moderate disease. And severe disease, not surprisingly, is where your optic nerve is getting pinched. So you're losing vision in dysthyroid optic neuropathy. Okay. Also, if you have corneal exposure so bad that your cornea is breaking down, some people get both. We've had a chap recently, actually, he's nearing 90 and he's got both. So there's just some photographs of some of the signs that you grade the disease by. So that's clearly active edema, fluid under the eyelids. It's not just fat prolapse. This is active fluid under the lids and the upper lids. So that's clearly lydodema. This chap, he has marked lydodema of all 4 lids. He hasn't got it, the lids aren't red as such, so he doesn't score for that. Boy, does he score for redness of the eye. He's definitely red and very marked chemosis. So there's a lot of fluid under his conjunctiva. So he's very, and his caruncle is swollen. So like he's scoring for loads of factors there. So he'll have quite a high CAS score. And he'll be about a 7, I think he was. This is eyelid erythema where the lids go red. And you see that sometimes. This person has conjunctival erythema as well. And this is swelling of the caruncle, so that gets swollen up there, so that scores as well. So basically, you assess all these things. They end up getting a score. The initial score is out of 7. When you see them subsequently, it's out of 10. But so you score that, and that gives you an idea of how active they are and whether you're dealing with active disease or not. And if you think it's active, you can figure out whether it's mild, moderate, or severe. So if you've got someone with active disease, they've said, oh, this kicked off in the last 3 months, and you score them and they're a 6 out of 10, and they've got double vision, you think, well, maybe we'll start treatment for this person. Things can vary too. Like she's not that injected, this lady, but it's hard to see that she's quite proptose and she's got a bit of retraction. She hasn't got much lydodema, a bit up here in the upper lids. But this was definitely new. It was definitely active. So not everybody fits the bill. Here's someone who's got lydodema, gross lid retraction, lydodema again, gross lid retraction, but her conjunctiva is surprisingly white. Here's someone with poor eyelid. They've got a gap on attempted closure. They're proptose, and it's hard to, that's an ulcer there on the cornea. They've got an ulcer. So that is sight threatening because they've got an ulcer. Measuring exophthalmometry is done with an exophthalmometer, not surprisingly. And you're measuring how far forward the eyes are pushed as compared with the orbital rim. And you also need to look at fundoscopy. Fundoscopy is very important because this is the same person and disc on the right is normal. Disc over here at gross swelling of the disc. As they had barn door dysthyroid optic neuropathy. And visual fields might become constricted if the optic nerve gets pinched, so it's beginning to get constricted there. Yeah, so again, assess it all and get your clinical activity score and decide whether it's mild, moderate, or severe, and then base whether you're going to treat on that. A workup, well, as you might expect, the usual bloods, TSH receptor antibody, a scan to look for muscle enlargement. If you're thinking of rituximab, you need to do a quantiferon test, check for Hep B so you don't reactivate that. A good photo is always helpful as well. So this CT is showing pretty marked muscle involvement and pretty bad right back at the apex. So that's likely to give them dysthyroid optic neuropathy. MRI is good for showing activity of the disease sometimes because the muscles light up. And you can see, again, grossly swollen medial rectus, inferior, lateral, and superior there. And even the obliques are swollen, so they're much more than this side. Still a little bit of room for the optic nerve there, so they might be okay. So treatment for everybody from mild to severe, for everybody, you want to normalize their thyroid function, right? And I'm glad Russell is gone because I'm not an endocrinologist, but they do say you shouldn't use radioiodine, preferably not if they've got active disease, and use anti-thyroid drugs instead. Try and stop smoking. And cholesterol does seem to be linked as well with thyroid eye disease. If they are having radioiodine, they need to get steroids to cover them as a prophylactic measure. And you do try to avoid iatrogenic hypothyroidism. So if you give them radioiodine, watch out for that crash that can happen and try and prevent that before it happens. So for everybody, mild to moderate to severe, lubricants to help protect the cornea. Oral selenium has been shown to help. It's just a trace element. I can buy it in Holland and Barrett, and that has been shown to help in mild cases. You can sleep propped up. Prisms can really help with the double vision. Botox to your levator might drop the upper lid to help protect the eye. A note on smoking, again, we do keep banging on with this, I'm sorry, but it does. So it increases your risk of developing thyroid eye disease. You get it worse, and you're more likely to get a problem if you have radioiodine if you smoke. The treatments that we give are less effective, and the disease just drags on. And like sometimes things you read in the literature don't exactly pan out in practice, do they? But honestly, it's two groups in the clinic. There's the non-smokers and there's the smokers. And poor smokers do badly. So treating, what do we do? So generally we follow the UGOGO protocol, and that is to give intravenous methylprednisolone in combination with mycophenolate. So that is what is recommended now. So those two together. Other second-line treatments might be other immunosuppressives like cyclosporin. We don't use it that much, but that is another recommended one. Orbital radiotherapy can be useful. Oral prednisolone in combination with orbital radiotherapy has been used. If you're struggling, rituximab or other monoclonal antibodies. And if you're really struggling, that's when you call your head and neck pal and you look for an urgent decompression for dysthyroid optic neuropathy. I'll go through those. So intravenous methylprednisolone, the evidence is very good for it. UGOGO scored them. The way they scored it was they gave their evidence out of 4, and they got a 4 out of 4 for intravenous methylprednisolone. The evidence is good for it. So you give 500 milligrams every week for 6 weeks, and then 250 milligrams every week for 6 weeks. You start mycophenolate at the same time. And so that's our kind of standard treatment. Obviously, you give them you prevent peptic ulcer disease, give them something to prevent osteoporosis. Mood can be the biggest thing, actually, we find. Most people don't sleep the first night. Some people find it so mood altering they can't continue it. But that's rare enough. You do better on intravenous methylprednisolone than you do on oral. 77% response rate versus 51% for the oral, and less side effects with the intravenous. Upping dose, but you get less side effects with it. I think it's because it's once a week rather than every day. You get less of the weight gain, you get less of all the problems, and it's more effective. Mycophenolate, the evidence is very strong for mycophenolate again. 4 out of 4, UGOGO gave it. I thought this was quite interesting. So it works by inhibiting inosine monophosphate dehydrogenase. Now, inosine is a precursor of adenosine and guanosine. So A and G in the, AT and GC in your DNA. So I quite like the idea that it was important for your DNA, but it's also a flavor enhancer. So it's also important in your pot noodle and your Pringles crisps. So it's multifunctional inosine. Anyway, mycophenolate, yeah, that's how it works. But you get apoptosis of the T cells, and it inhibits the fibroblasts. So mycophenolate particularly good when used in combination with methylprednisolone, and that is now it's considered the standard of care. Okay. And the great thing about it is if you start them on mycophenolate, when you start the intravenous methylprednisolone, by the time you're finished your methylpred, the mycophenolate is kicked in. So you stop your steroid and that'll hopefully keep them in remission. Whereas before you stop the steroid and everything, it kind of bounces back. So the mycophenolate is great for that. Obviously, every drug has side effects and you've got to watch out for those. Bone marrow suppression, you check them weekly for the first month. Cyclosporin and azathioprine can also be used. But evidence is slightly stronger for mycophenolate. Low-dose orbital radiotherapy, the evidence has grown for that over the last couple of decades. Now you go give it a 3 out of 4. So it's given in I think it's about 12 fractions. It could be wrong on this. They make a mass first, and then you get about 12 fractions. So it's quite labor intensive for patient and doctor. So they have to go like about 13 or 14 trips to the radio-oncologist. Rituximab, yep, we do use this when all else has failed, kind of thing. So if you've got someone who's got sight-threatening disease, either from dysthyroid ophthalmopathy or if their cornea is breaking down, you can consider rituximab. And you've tried the steroids and you've tried the radiotherapy and you've tried the mycophenolate. Rituximab is an option. The evidence for it is not as strong. The way it works is by leading to B cell depletion. Some studies very positive, others not so much. So yes, when your back's to the wall, it might be useful. And obviously you got to do a quantiferon test and check for Hep B before you. So it's just 2 doses. It's just 1 dose, gap of 2 weeks, and another dose, and that's it. Tocilizumab, that can be used as well. I don't have experience with it, but it is a potential second-line treatment. What do we do for the sight-threatening people? Sorry, I'll just check the times. Sorry, I'll speed up a bit. So the sight-threatening, so if they've got visual loss, right, reduced color vision, abnormal pupil reactions, abnormal fields, and a swollen disc, they've got dysthyroid ophthalmopathy. So you give them a gram of intravenous methylprednisolone, skip a day, give them another gram, skip a day, give them another gram. So they get 3 grams of intravenous methylprednisolone. If that works, great. If that doesn't work, we're on to our ENT colleagues for an urgent decompression. So they'll usually do the medial wall and the medial floor of the orbit because that gets back nicely back to the apex of the orbit and decompresses it well. Whereas a lateral wall decompression is very good cosmetically, but not as good at decompressing for dysthyroid ophthalmopathy. So this is just a summary then of that. So giving your high dose of steroids, adding in mycophenolate, that's our first line of treatment. Second line of treatment can be you can give them steroids again if it's failed. You can consider oral prednisolone with cyclosporin, orbital radiotherapy with or without steroids, and rituximab, tocilizumab, and then this new thing, teprotumumab, which you may have heard of. So this has caused a bit of a stir. I'll mention that in a sec. So treatment is a bit of a balancing act. Okay. You might have 2 people with active thyroid eye disease. Okay. One is 80. She's got diabetes. She's retired. She gets diplopia when she looks left and right. Would you treat her? Maybe not with steroids. Other person, active, diplopia and looking left and right. He's 45, he's a pilot. And then maybe you would. So like all things in medicine, there's a bit of a balancing act between risk and benefit. Future mAbs. So teprotumumab looked extremely promising there about 2 years ago. So the fascinating thing about this is it actually caused a reduction in proptosis. This was new. This was groundbreaking for us because up till this, yeah, you got the inflammation under control, but you didn't reduce the proptosis generally. This reduced the proptosis and reduced the clinical activity and improved the quality of life. So yeah, it looked fantastic. And what were you doing if you weren't using teprotumumab? Really, you were an outlier. How does it work? So we can go on to this one. It binds to the, so under normal circumstances, there's the IGF receptor and there's the TSH receptor, and TSH antibody binds there. Okay. So then with teprotumumab binds here to the IGF receptor, blocks the IGF antibody, and that stops. That has the effect of changing the shape of the receptor and stops the TSH antibody binding. So cost. Well, intravenous methylprednisolone and mycophenolate together in US dollars comes to about $1,000, okay, for the treatment. And the cost of teprotumumab is $360,000 for a 21-week course of treatment. That is over £250,000. So not surprisingly, it isn't approved yet here. So, and there's a paper came out there in July as well. So all things look fantastic initially, don't they? And the approval for teprotumumab was kind of rushed through a bit because it reduced the proptosis and that. But with time, it's been shown that, well, basically, the initial study had an endpoint of 24 weeks, but the transfusion took 21 weeks. So essentially, they were looking at it just when you finish the treatment, probably at the best time to look at something, right? This new study looked at things 1 and 2 years down the road, and they found that, yes, it is fantastic. It does reduce the proptosis by 3 millimeters, but only a third of people maintained that reduction with time. Yes, it is fantastic at reducing the inflammation. 90% had a reduced clinical activity score, but 50% regressed over time. And you do get muscle spasms, fatigue, alopecia, nausea, and worryingly, hearing loss can be a problem. So it isn't the total holy grail we're hoping for. So everybody's now hoping for to find the magic drug. So Roche have started a trial with one they call it satralizumab. As far as I know, it's a variant of tocilizumab. It's a longer acting one. They've modified the stalk of the antibody, as it were, the trunk, the FC portion, and so that it has a longer half-life. So it's just a subcutaneous injection every 4 weeks, which would be fantastic if it worked. So there's a trial now going on worldwide, and we're lucky enough to be involved in it. And so we're currently recruiting in Glasgow. So I'm nearly finished. So what about inactive cases? Rehabilitative surgery for when the disease is inactive. An orbital decompression really can work wonders for someone's appearance. Okay, it really can. And once you've decompressed the orbital or the eyes go back in, the lids often follow suit, not always. You might also need squint surgery to improve their double vision, try and get them double vision free in the primary position, and drop their upper lids as well and raise their lowers. And here's so you can see she's got marked retraction of her eyelids, proptosis, and that's her after a bony decompression. You can still see the scar still there, so it's pretty recent. So it improves a lot of aspects. What's also interesting, and people talk about this in thyroid eye disease, it's not just your eyes, your face gets involved. So her temple is fuller than there. She's got cheeks here, she doesn't here. And someone was talking about this at one of the meetings. It changes your face as well. It doesn't just change your eyes. And that's not just the steroids, it's even pre-steroids. The thyroid eye disease does change your face as well. So in summary, stop smoking. So if you can, get people to stop smoking before they get the disease. Manage in a joint thyroid eye disease clinic. Assess the activity and severity and base your treatment on that. We use the UGOGO protocol, as I was saying, which is mycophenolate and intravenous methylprednisolone. And the treatments we described. And for sight threatening, yes, high dose and an orbital decompression. and then rehabilitative surgery for them when they go quiet. So it's really a classic example, thyroid eye disease, of working together or joint care, because we've got the orthoptists, the nursing crew, help from our ENT colleagues, endocrinology, radiation oncology, and it's all those things that end up giving someone a good outcome. So if you guys come across a fresh new case, we're dying to have it, and because the earlier we get them, the better the treatment works, and also we could consider enrolling them in the trial as well. And so yeah, you can, if I think a letter, well, what happens to us in Glasgow is the letter seems to go into space somewhere, bounces around a bit, and eventually gets to the person it needs to. And by that time, the disease has either done its worst or burnt itself out. So email us if you think you've got a new, fresh, active case. And that's it. Thank you very much. Thank you. Sorry, I dragged on a bit there, I think.
Kevin, thank you very much. I've got a quick question. You're actively recruiting in Glasgow. Are there other centres in Scotland that are recruiting for this, or would you look from other areas?
We would, yes.
Okay.
We do. We see thyroid eye disease from other areas. We don't want complicated ones. Yeah.
Okay.
We're happy to see them. Yeah.
I've got to say, I mean, you do run a fantastic service there.
Well, it's Paul and myself. It was, so we've been the last 3 years now, I think. Yeah.
Okay.
So,
any questions from the floor?
So I got one question.
yes.
So what's the percentage patients go for severe eye disease or visual threatening?
Yeah, about 3% of patients who get thyroid eye disease get sight-threatening disease.
Right.
And the dysthyroid optic neuropathy is more common than the corneal problems. So yeah, it's usually, if it's sight-threatening, it's usually dysthyroid optic neuropathy. About 3% of them. Relatively low.
Yeah.
But,
Still significant.
but it's still significant. And, we've had several, and they're very challenging.
Thank you.
Do you prefer surgery for treatment of thyrotoxicosis to radioactive iodine?
So I've been to, there was a meeting down in London about thyroid eye disease, and if you have a medic talking, he'll say that radioiodine is good and doesn't have many side effects, and all the side effects are controllable. And then if you have a surgeon talking, the surgeon will say it's better. Now, what do we find as eye doctors? This is only an impression, but a lot of us there at that meeting in London, we found things seem to go very quiet after a thyroidectomy, after the surgical option, whereas things can kick off after radioiodine. You have to be quite careful with radioiodine to give steroid prophylactically, and also to avoid the iatrogenic hypothyroidism. So you give them a little bit of thyroxine before they crash. Yeah.
I mean, certainly in Glasgow, I think that if they're referring on to yourself, they refer to us for surgery at the same time in preference.
Yeah.
But I know some other areas do give RAI.
Yep.
Despite.
Yeah. Don't think there's, like, evidence-wise, I don't think the work has been done to show that. But we think as ophthalmologists, our impression is that after a thyroidectomy, things seem to quieten down. Everything seems to quieten. But that's one impression.
Thank you very much.
Good. I think there's one question from online. Is there any evidence in the management of unilateral versus bilateral thyroid eye disease?
No, I suppose is the answer. And again, you base it on if it's got to figure out, is it active first? And if it's active, then how bad is it? And if it's, if they've got diplopia, well, you're probably going to treat, because most people are driving. They don't want, diplopia is very disabling. You can't handle stairs. So by the time it gets to moderate, which is diplopia or bad lid retraction, you're probably going to treat, unless they're quite unwell. Otherwise, diabetes really can make things difficult. Obviously, if they're severe, you pretty much have to treat to preserve their vision. And if they're mild, you can just get by with selenium, lubricants, and that. So to answer your question, no real difference between unilateral or bilateral. You just treat according to how active it is and how bad it is.
Brilliant. Fantastic.
Okay, super. Thank you very
Excellent.
much.
Thank you.